Good day, listeners. Today is August 16th, 2022, and this is Tejas Shah. I'm a member of the Public Affairs Committee of the North American Spine Society, or NASS, and I'm a current PM&R resident at the hospital of the University of Pennsylvania in Philadelphia, Pennsylvania. I would like to welcome everyone to the next installment of our podcast series, showcasing interesting articles from the upcoming SpineLine NASS membership magazine. Today, we'll be discussing the article co-written by Dr. Brian Simpson, Dr. Michael Stanton Hicks, and Dr. Simon Thompson, titled Failback Surgery Syndrome is the Problem. Persistent Spinal Pain Syndrome is the Solution, in the July-August 2022 issue. You will have the pleasure of hearing directly today from Dr. Brian Simpson. Before we get started, Dr. Simpson is with us today, and I'd just like to have him introduce himself to all of us.
Thank you very much. Well, I'm a British neurosurgeon, actually a retired British neurosurgeon here in Cardiff in the UK. I worked for 25 years as a consultant neurosurgeon at the University Hospital of Wales, and I retired from clinical practice just over 8 years ago, but I've obviously maintained various academic interests and so on. My medical education and training started off at Cambridge University and continued in London at the London Hospital, now known as the Royal London Hospital. And that's where I also did my neurosurgical training. We weren't so, specialist fields weren't so specialized, or subspecialization wasn't so exclusive in the earlier part of my career. So I had a very broad grounding in neurosurgery, but my subspecialty interest was functional. And originally movement disorders was my main interest, but pain gradually took over, as I think it has a habit of doing, and I became very involved in neuromodulation. I was president of the International Neuromodulation Society from 2000 to 2003, and I still keep close links. It's an interesting thing just to note that, of course, what is currently referred to as failed back surgery syndrome is the biggest single indication for spinal cord stimulation.
Yes, thank you so much for pointing that out, and thank you so much for that introduction. Just an aside, I'm a PM&R resident, and I'm interested in neuromodulation as well. Quite recently, I actually did a sort of a grand rounds on spinal cord stimulation, and you're 100% right. Failed back surgery syndrome is the most common indication for it, and I believe the second most common currently is chronic regional pain syndrome out here in the United States. So I think that's fantastic. Thank you for recognizing that. My first question to you, Dr. Simpson, is how did this project come about and develop?
Well, we're going back 5 years now. My old friend Mark Russo in Sydney, Australia, contacted me one day in August 2017 and said, look, another colleague, Nick Christelis, pain specialist down in Melbourne, the two of us really want to get to grips with this awful term, failed back surgery syndrome, and we want to do something about getting rid of it once and for all. Will you join us? They'd already drafted a scoping paper, and we very quickly recruited Michael Stanton Hicks from the Cleveland Clinic and Giancarlo Baralat from Denver, Colorado. And we formed a sort of small steering group. We put together a total of 25 of us, international multidisciplinary panel. We worked through emails and so on, and ended up with a structured workshop in Sydney in 2019, the conference of the International Neuromodulation Society. And there we had 14 proposals for terms to take over from failed back surgery syndrome. And some of those have been published, and we condensed these to a short list of 4. Each of those 4 was presented by the proposer, and I was delighted when persistent spinal pain syndrome was selected as the favored candidate. We finally published this work in full in Pain Medicine last year. And obviously there's more detail in that paper than there will be in the SpineLine review, or that we'll be able to cover today, of course. But that is open access, that paper in Pain Medicine, volume 22, page 807.
Oh, thank you so much for the reference, very specific reference. Definitely sure to check that out. And I definitely recommend all the listeners to do that after this podcast. So failed back surgery syndrome, you as a retired now, but a former practicing neurosurgeon obviously saw this all the time in clinic, as well as in the OR. Can you tell the audience, especially to the audience that's not familiar with this, soon to be hopefully former syndrome, what's really wrong with the term failed back surgery syndrome, since it's been around for so long?
Well, a lot of things are wrong with it. Our panel came up with a total of 13 different issues. I'm not going to go through each of those now, obviously, but to summarize, first of all, it's generally a very unclear, rather limited term. It's a sort of shorthand approach to a problem which is very complex. It doesn't even distinguish between whether the surgery caused the pain, exacerbated the pain, or simply failed to relieve the pain. It doesn't deal very well with recurrent symptoms, with relapses. It doesn't say anything about inappropriate surgery, for example. Was the surgery done wrong? Was it done in the wrong place, at the wrong level, just not done properly? Was the surgery not indicated in the first place? I mean, it doesn't sort of give you any lead on or weigh in on any of this. It doesn't tell you anything about who or what failed. And of course, it's also very pejorative. It's a stigmatizing term. When you put those two words, failed and syndrome, together in one term, a syndrome of failure, it's not a good look, is it? It doesn't encourage optimism, or it doesn't encourage a good attitude. But the cardinal problem is this issue of the ambiguity over the causation of the problem. And this has consequences. You have an inaccurate term like this, a poor classification. It tends to get in the way of research, of data gathering, and of course, perhaps most importantly, it impedes patients' access to appropriate treatment. In mitigation, you might say that, well, this term was introduced over 40 years ago, and it was a different world then. We didn't have the sophisticated imaging. We didn't have such advanced knowledge of pain mechanisms. We didn't fully understand, or really have much understanding at all, of the influence of psychological and social factors in these syndromes. So I think one has to take that into account. But it's now 40 years down the line, and it's overdue for replacement. Yeah.
Thank you so much for the explanation. Very thorough and definitely spelled out in the book, right? I mean, I spelled out in the article rather. Failed back surgery, right? I mean, essentially you have surgery usually because there's a problem. People have, remitting pain that's not being, relieved. So when you have failed back surgery syndrome, like you mentioned, it doesn't really tell the provider, what happened to that pain. Did the surgery cause new pain? Did the surgery just not relieve the original pain that was going on? I can imagine the stigma, as you also alluded to, how it would be if there was a syndrome called failed epidural corticosteroid injection, right? So I definitely agree with that. And I think it's great. And I think that's one of the great, reasons the article spelled out as to why a name change was needed. And probably 40 years is too long for a term to stick around anyways, especially with how, medicine changes day to day, especially in the field of neuromodulation. You did, say that this term has been around for so long, rather. What do you think were some of the barriers, or why do you think the term FBSS has not been replaced before?
I think some of the terms that have been suggested and published have really just been perhaps too vague. And some of them have been quite cumbersome, long phrases, and it's difficult for those to catch on. But I think the main reason, and this is central to the whole thing really, is that any term that makes reference to surgery, and most of the suggested replacements do, after surgery, post-surgical, and so on, I submit that always implies, or can always imply, causation. It's trying to tell you the surgery caused the problem, whether it did or not. And this is a very strong thing. I mean, if you talk about diarrhea after drinking the water, that doesn't just mean you drank the water before you had diarrhea. It means a lot more than that. It means that the water caused the diarrhea, postherpetic neuralgia. And the examples are many. And I think the only way in to have any hope of getting a term that'll stick is to decouple the surgery from the symptoms, from the syndrome. Yeah.
Thank you. Exactly. And obviously, again, more the reason, for the name change. Why did we go with the term persistent spinal pain syndrome?
Well, I think you just have to start off by asking, I mean, the way I thought, the way it sort of came to me, and I sort of thought about it, was you take a big step back, forget surgery, just forget surgery, and ask, why is chronic pain of spinal origin so prevalent? Why is it so persistent? Why is it often so disabling? And why are the reoperation rates in spinal surgery for pain so much higher than reoperation rates for surgery in really any other non-malignant condition? And I think the answer is that you have to take a more fundamental approach. You have to take an approach which is not pivoted on surgery, not predicated on surgery. My suggestion was to focus on the notion, if you like, that the upright posture is work in progress from an evolutionary point of view. We're at an interim stage in the evolution of the human spinal system, skeleton and soft tissues. And it's obvious, really, but you're not automatically aware of it. It's effortless, the upright posture. It's natural, it's what we do. Unless it's actually hurting you, you don't take any notice of it, you just do it, despite the considerable forces involved. But I would invite you to consider this. The vertebrate skeleton, the morphology, the template of the vertebral skeleton has been around for a very, very long time. It's been around for probably about 500 million years without fundamentally changing. Of course, it's adapted and there's been changes, but the fundamental template has been around for 500 million years. It's adapted to swimming, to moving around on land, to climbing, and to flying. And the sizes of vertebrates vary enormously. Vertebrates come in a few grams, others weigh millions of grams, but they're all vertebrates. At the moment, there are about, present time, probably about 50,000 species of vertebrates on Earth. Goodness only knows how many species have come and gone in 500 million years, but there must be a few. And in all those huge numbers, those huge ranges and so on, which are almost too big to take in, only one species has ever fully adopted the upright posture. And I think that has to be relevant. And why should we assume, therefore, that the evolution of our spine is complete? In evolutionary terms, we've only been using the upright posture for about 4 million years out of 500 million. That's not long in evolutionary terms. And there's recent evidence that the human spine is changing. Our spines are different from Neanderthal spines from 200,000, 300,000 years ago, and even less. It's disputed, it's not sort of firmly established, but it does seem that the Neanderthal spine was straighter. It didn't have the same degree of curvatures that our spine has. A very interesting recent evidence earlier this year suggesting that as recently as 200 years ago, changes took place in the lumbar spine as a result of the Industrial Revolution and changes in activity, changes in lifestyle. That may, I mean, clearly this is not, this is not gospel. I mean, but this is an interesting proposal with some evidence that as recently as 200 years ago, visible changes took place in our spine. So why should we be at the peak of its evolution? So the point is that it's not yet able, the spine is not yet able, I would say, to handle the unique forces that it's subjected to through the upright posture. So, we should start from the premise that what this leads on to logically is the premise that human beings are intrinsically vulnerable to chronic pain of spinal origin. They're intrinsically predisposed to it, they're vulnerable to it, and not only to the chronic pain, but to its persistence. None of this is new. I mean, I'm not giving you groundbreaking new knowledge. It's just that looking at it this way gives you a good starting point, I think, to build a new terminology from a more logical standpoint. Now, just the last bit of my answer to that question is very specifically, why specifically that 4-word term? Well, I originally proposed persistent spinal syndrome, just to emphasize the principle. I was looking back over my correspondence when I was preparing for this, and somewhat to my amusement, I found that I first suggested that term, persistent spinal syndrome, on the 16th of August, 2017. So 5 years ago to the very day was the first time I raised that as a possibility. Now, our group accepted that the principle was okay, but there was a lot of discussion about this, but it was fairly decisive. It should include the word pain. It had to include the word pain. I think the first person who pointed this out was Giancarlo Baralat, and that's fair enough. We had a lot of discussion about whether it should be persistent spinal pain syndrome or chronic spinal pain syndrome, and there is a bit of a shift towards the use of the word. The two terms are very different. They have very different meaning, and it's something I've really felt quite strongly about. Chronic is just a simple quantitative adjective, a dimensional adjective in time. And it's no different from adjectives that relate to speed or distance or weight. It tells you no more than that it lasted or has lasted usually 3 months, maybe 6 months, usually 3 months. Persistent tells you a lot more. It's a different kind of adjective. And it means that the chronic pain persisted despite something. Despite a change of circumstances, of lifestyle, despite optimal medical management, despite surgical intervention, this pain persisted. So we kept persistent in there. Why syndrome? Well, if you just said persistent spinal pain, it would imply that it was persistent pain in the spine, like persistent pain in the chest or rectum or foot. And that's not what we're talking about. Is persistent spinal syndrome. And a syndrome, of course, is a random, non-coincidental cluster of symptoms and signs. It's complex, and that's exactly what persistent spinal pain syndrome is. So it protects the word spinal from misunderstanding and gives the term its right meaning. So that's sorry, I've gone on a bit, but that's how it that's how it developed and was sort of finalized.
No, thank you. That was an awesome explanation. I really appreciated the history lesson. And it's amazing to see how like almost every word of that 4-word phrase had so much, meaning and depth behind it, especially when we try to tackle something as complex as, just back pain, right? I mean, I think as a current doctor in training or resident, as we call it here in the U.S., we're all trained on figuring out the generator of the back pain, right? So it's always important to get the classification right if we're going to have a proper management approach, if the management approach is different for depending on where your pain's coming from. Sometimes the pain could be coming from your shoulders or your hips, depending on what you find on physical exam and imaging. So very, very important to be able to distinguish that. And I really appreciate the explanation for that and how much thought really went behind it. I think it shows the medical community, the international spine doctors comprising of physiatrists, neurosurgeons like yourself, as well as orthopedics or even primary care doctors, the importance of, being able to put people, our patients, in the right category so they can get the best management for them. My next question to you is that around the time that this term was coined by you and your colleagues, the new version of the International Classification of Disease, or ICD, also came out. Did that play any impact into the naming?
Well, yeah, I mean, this was a major event, the 11th iteration of the internationally accepted classification of disease. And for the first time in this iteration of it, chronic pain was included as a disease entity in its own right. And within that, they proposed the term chronic pain after spinal surgery. And we had a sort of collective heart sinking and thought it was really game over. They've beaten us to it. Fortunately, that was wrong. Because when you looked into it a bit more carefully, the definition of chronic pain after spinal surgery has been given a very narrow, specific definition, which is that the pain is caused by the surgery, or is probably caused by the surgery. They had to do that in order to avoid the very ambiguity of causation that I've been talking about, that you have in failed back surgery syndrome and that you have in most of the previously suggested replacements. If they hadn't done that, this term would have been equally ambiguous, and it wouldn't have worked. So, because it only covers a minority of patients who would previously, or who would still, come under the umbrella of failed back surgery syndrome, this left a door open, because persistent spinal pain syndrome deals with everything else. And it can include chronic pain after spinal surgery. That limitation on that term, for example, doesn't even include failure to relieve the pain. And also there's a lot of other aspects. So it's so specific, it can't replace failed back surgery syndrome on its own and completely. Failed back surgery syndrome being, apart from being a dreadful term, is obviously much broader. Persistent spinal pain syndrome can fit in, actually. We've devised a way of, sort of proposed ways in which it could be fitted into ICD-11, and it would be complementary, and it would work.
Thanks for sort of clarifying that and further, I think, compounding, I think, on the name and the reason why it is this and not some of the other terms that, we looked at. To summarize, can you tell our listeners just the main key points of this phrase PSPS, or persistent spinal pain syndrome?
Yeah, thank you. Well, first of all, I haven't given you a definition of the term. So I'll do that if I may now. And what we're saying is persistent spinal pain syndrome is a persistent pain of spinal origin with or without associated neurological symptoms, which can be axial, radicular, or a mixture, and applying to any spinal level. And that bit's important, because we're not just talking about the low back and the lumbar spine. This also applies to failed neck surgery syndrome. We have type 1, PSPS type 1, which is despite optimal non-surgical treatment. So there's been no surgery at all, no relevant surgery at all. It's type 1. Type 2, surgery took place. It can be directly or indirectly causative. It might be non-causative, or it might be unclear. And the pain persists despite surgery. It may even persist because of surgery, and that would be chronic pain after spinal surgery, which our term includes. It's a broader approach. It covers all the shortcomings of failed back surgery syndrome. It addresses the problem in a multifactorial and fundamental way. It avoids the ambiguity of causation. It's predicated on the upright posture and not on surgery. It applies to the whole spine. It can integrate with ICD-11, where it has a unifying, or would have a unifying effect. And it can fully replace failed back surgery syndrome and failed neck surgery syndrome. It provides an accurate and meaningful terminology and classification, and this would improve access to appropriate treatment. It should also improve the expectations of both practitioners and patients. I would just mention that although this principle, there's a persistent spinal syndrome principle, was my suggestion. This is the end result of a project representing the work and interactions of a large group of experts and specialists.
Finally, to provide closing thoughts, Dr. Simpson, how do you see the way forward for PSPS?
Well, it's going to take time. It's already taken quite a lot of time, but it's going to take more. What we need, of course, is official recognition. We need to get it incorporated into ICD-11, and with coding and so on. I can't see that happening without widespread acceptance and adoption in the profession and the community first. Members of the panel have been spreading the word verbally and in print. And then there's journals to consider. We've been working very hard on the journals. I've personally written to the editors of 25 journals, had positive responses from 17. 5 of the editors have published letters about PSPS. 4 of them have said straight away that they would switch. In their journal, they would require this term to be used instead of failed back surgery syndrome. Another 4 said that they couldn't make that commitment at this stage, but they would seriously consider switching. So we're getting somewhere already. It's already the pain medicine paper already has well over 40 citations, and the term persistent spinal pain syndrome is already beginning to appear in the titles of some publications, which of course is very encouraging. But we just need more and more of that. So far, so good.
Yeah, no, certainly, possible ways to go, but it's great to see that there's been, certainly some progress made. And, who knows what the timeline holds, but no, it'd be great to definitely see some progress in it. And I can see that you're working, obviously, to do your part in advancing that portion. So that's fantastic to hear. That about wraps it up for me. I just want to first, obviously, thank you for your time that you provided here. To all the listeners who tuned in, would like to thank them as well for joining us on our NAS Public Affairs podcast. I'd like to acknowledge, of course, the help from our wonderful behind-the-scenes people you don't hear from or see. But that includes, of course, Jeff Karzan, Pamela Town, as well as Brianna Schaefer. Again, my name is Tejas Shah. I'm a third-year P.M.R. resident here at the Hospital University of Pennsylvania, signing off from Philadelphia, Pennsylvania. And don't forget, to all the listeners, stay spine safe.